Welcome to Variations 4, the genitourinary unit. We're going to be talking about questions 4 and 5 in this video. Just a quick overview of hemodialysis, otherwise known as HD, and peritoneal dialysis, PD. We'll also go over, in fact, what we'll start with is actually number 5, which just takes us through a quick head-to-toe consideration of acute renal failure. So let's start with let's start with question 5, the head-to-toe diagram, and then we'll come back and talk a little bit more in detail about the dialysis options. All right, so just looking at map 6 here, it's given what we just talked about in the last video. I'm hoping that most of these points here are really intuitive. Just in terms of psych health, spiritual being, kind of meaning and connectedness in the world, you have to ask yourself how it can be for patients who suddenly, because of acute renal failure that may progress to chronic, how it might be to them to have to come to a clinic to get hemodialysis 3 times a week. That can really impact lifestyle and play on the psychology. That's just one. There's many different directions you could take that point in. A lot of this other stuff here is pretty self-explanatory. We've talked about the acidosis, edema, lights. In terms of food intake, fluid restriction above is pretty common because if their GFR is not working well, then they're holding on to fluids. So we may want to work at restricting fluids. Usually it's about 1 to 1.5 liters a day, the restriction. They get weighed quite often to ensure that they're not putting on too much water weight. Calorie intake management, just a point around this is this point at the bottom here, protein and potassium. Because we saw that, potassium could be high, it could be low in the diuresis phase, but in acute renal failure, we saw that it could be high for various reasons. Maybe acidosis, maybe just the renal failure in general is causing potassium to build up in the body. So we want to be watchful of that, monitor that, do whatever we need to do in terms of lowering it. We talked a little bit about that in the last video, and watch our diet around that. Protein's another one. If urea is going up, we already talked about how protein gets converted to ammonia and then gets converted to the waste product urea. Well, if urea is high in the body, we may need to consider limiting protein intake too. Avoid NSAIDs. That's pretty common knowledge with renal failure. That's probably about it that we want to say for this diagram here. Let's get to talking about the question before that, question number 4, which asks about dialysis. So just quick points here, just kind of what's the difference between HD and peritoneal dialysis. Let's just look at a quick picture here. And I'll kind of talk through some of these points when you look at the picture. And just remember these points are listed here for your own reference and study. But let's look at a couple of pictures. So here's a picture of someone getting hemodialysis. Typically, they'll have a central line in them, or not even a central line, sorry. They'll have like a, a hub that's basically installed. They'll have a hub within their arm that they can get an IV connected to. And it is like a central line in that way in terms of where it goes to. And it stays there, and like a portacath, that's the word I'm looking for. It's called a portacath. But anyways, they have the IV attached to this portacath. And I mean, dialysis, it's quite an exhaustive process. It takes blood out. You can filter the blood. You can add things to the blood so they can get, before someone goes to hemodialysis, they might have really high lights, for example, and you might be really worried. And then you find out they're going to hemodialysis in an hour and they come back and all their lights are normal. So we can take things out, we can add things in. Of course, it's easy to give a blood transfusion during hemodialysis. It kind of is a blood transfusion, and it can be in that sense. It's a circuit, and you can take things out and add things in, basically. It's fast, it's aggressive, okay? It's tiring, it's very tiring, can end up in hypotension, fatigue, um, and it's usually patients are getting this, a few times a week if it turns into a chronic thing. The upside of it, as you can see here in your notes, is that it changes things very quickly. You can make rapid changes. You can give blood quickly. You can um, settle out lower lights really quickly. So you can correct things quickly with it. This is the good news with it. Okay, so let's compare that with peritoneal dialysis. So just a little picture here. This picture here does a pretty good job in showing what we're doing with peritoneal dialysis. There's a peritoneum, the abdomen will have a port. And again, like the hemodialysis, this is a permanent port that the patient has. Of course, it's an infection risk right there, of course, but they walk around with this port, they keep it there. The nurse, and actually at St. Paul's, LPNs do this, but they're trained for it specially. They'll bring peritoneal dialysis works as follows. The nurse will hook up the this kind of Y site tubing, and from the top on the IV pole, they will instill glucose-rich fluid that flows into the abdomen, basically the peritoneum. That glucose-rich fluid is got a lot of oncotic pull because it's got a lot of glucose in it. If you're questioning any of that so far, you need to review Unit 1 again when we talked about oncotic pull, solutes, and even specifically glucose has a lot of oncotic pull. It's all in Unit 1. So it's got oncotic pull. It pulls fluids into the tubing. It doesn't pull blood cells. It doesn't pull proteins, just the water component, the fluids in, wastes and fluids, and then allows it to leave through this tubing here. So there'll be a bag laying on the floor filling with fluids that the nurse has to come and empty. So again, glucose in draws fluids into the tubing, and that fluid has wastes in it, and then that's exited out of the body. This can be done quite frequently as well, although I'm not exactly sure how many days a week someone will get that done. It might be even daily, but don't quote me on that part. But that's the essence of peritoneal dialysis. The good news with it, it is a much less aggressive therapy than hemodialysis, much less tiring, and is good for gradual gradual changes and ongoing maintenance. In fact, people don't come to the hospital for peritoneal dialysis. They're usually there for some other reason. It just so happens that they need peritoneal dialysis, so it gets done here. Most times people do their own peritoneal dialysis at home. So there's another kind of benefit to it. And if we just kind of click back here to the concept maps, you can see that basically we've kind of summed up all those points for peritoneal dialysis already. And then down here, there's another summary of what I had just said above in that picture. Finally, just talking about CRRT. We don't see this often. I haven't seen it often. It's called continuous renal replacement therapy. It's just good to know in theory. It's like HD, but a little less aggressive. It takes a little longer, and it's good for maybe people who are hemodynamically unstable because they need slower changes in their circulatory system and in their changes to what's running through their vascular space.